We are live.
Yeah, good evening to all. On behalf of Torrent Pharma, I take this opportunity to welcome you all on this webinar that is COVID-19 India and Diabetes. We would like to extend our heartfelt thanks to Diabetes India and especially to Dr. Bansi Sabu for giving us this opportunity to organize this webinar. I would also like to take this opportunity to welcome all our eminent faculties and today's chairperson, Dr. P.P. Mohan sir, Dr. Sanjeev Phatak, Dr. Bansi Sabu, and Dr. Mangesh Tiwaskar. We are very fortunate enough to have this all eminent faculty today. And I also extend my warm welcome to all the delegates who have joined from different locations from India. So I would like to introduce Dr. P.P. Mohan sir. Admin, can you share the intro profile? Yeah. So Dr. Mohan sir doesn't require actually introduction, but I am proud and privileged to introduce him. He's a director and HOD of Cardiology Westfords High Tech Hospital, Thrissur. He's a president of Cardiology Society of India, past national convener of Coronary and Non-Coronary Cardiological Society of India. He has got various publications to his credit, and he has largest acute coronary syndrome registry from India, that is Kerala ACS registry. Did a largest randomized study in cardiovascular science from India, and did a first quality improvement study in chronic heart failure in India. So over to Mohan sir.
Thank you, Dave, and my erudite faculty members, Dr. Bansi Sabu, Dr. Sanjeev Phatak, and Mangesh Tiwaskar, and my dear listeners. I have great privilege to introduce my friend, Dr. Bansi Sabu, who will be talking second, and he is the Chief Diabetologist and Chairman, Diabetes Care, the President of the Research Society for the Study of Diabetes, has been taking multiple key positions in the management of diabetes part. He has contributed immensely by way of propagating these informations through textbooks. He's also a founder and GE of Diabetes Care India, which is doing an excellent job, and has been an advisory board member of Journal of Association of India, Journal of Diabetology, JAMR, and innumerable publications with multiple awards, and very active in public awareness projects. And I had a long liaison with him, and especially that was cemented during the last year when we had the Cardiological Society meeting at Ahmedabad. So the next speaker I want to introduce is Dr. Sanjeev Phatak, who is from Ahmedabad, a senior diabetologist, has been the PI, site PI for more than 30 global clinical trials, and held many faculty positions in very many meetings conducted by RSSDI, EPICO, and Diabetes India, ex-president of the Association of Physicians of India, Ahmedabad, director of the Juvenile Diabetes Association, life member of many of the association, a recipient of many lectureship leadership award, and one of the first diabetologists to start the insulin pump therapy, and innovator of unique diabetes motivational health score. And we have finally Dr. Mangesh Tiwaskar, who is the General Secretary of the Association of Physicians of India, a very learned diabetologist physician. He has been also Secretary of the Physician Research Foundation, Indian College of Physicians, has been advisory committee member of American College of Physicians, a past governing body member, very many affiliations, has been in the editorial board of multiple journals, guest editor of some of the journals, and many publications, member of very many societies. So we have a very strong panelist, faculty to discuss with diabetes and COVID. And interestingly, now patient with diabetes has been on spotlight right from the time when the pandemic began in 2019. And the very many epidemiological studies has sort of cautioned every one of us that now when diabetes people get COVID, that augur not so good outcome. And it is also interesting to note that there is some sort of a bidirectional relationship between COVID-19 and diabetes. No, you have evidences showing that the virus can potentiate even inside diabetes. And again, diabetes, some of the when some diabetics develop that,
Yeah.
of course, it's a heterogeneous disease. Not every diabetic may behave the same way, but it's seen that the hazard ratio is very many. So to talk about the entire things, may I have the pleasure of inviting Dr. Sanjeev Pathak first, and he will be discussing basically about the mechanisms of diabetes by the COVID virus and many things. Over to you, Dr. Sanjeev. I will request every other, apart from the speaker, to mute so that the speaker is uninterrupted.
Thank you, Dr. Mohan. It is indeed a pleasure to be sharing the platform with greats like you, and of course with my close friend, Dr. Banshi Saboo, Dr. Mangesh Tiwashkar. And thank you very much, Torrent, for giving me this opportunity to share my views and my observations about the topic which I have been assigned to, the parting gift of COVID, that is diabetes. Maybe type 1 also, but most of the times type 2. May I be allowed to share my screen now, Amish bhai?
Yes, sir. Yes, sir. Yeah.
So I'm not able to see my presentation.
Dimple?
Yes.
Yeah. Sir, you can share your screen.
Yeah, that's right, but I'm not able to see the presentation. It's very much open, but can you see my slides?
Not yet. Not yet.
Doctor, if your presentation is open, can you come back to Zoom and click on share? Yeah, it's done.
Yes. Sir, you can make it full screen. Yeah.
Yeah, I'm making it, but somehow, yes.
Yeah, visible, sir.
Is it okay?
Yeah.
All right. So once again, thank you very much, Torrent and Professor Mohanan, for inviting me. And as discussed, I'll be discussing about COVID's parting gift, diabetes, and whether diabetes is associated with more mortality in COVID patients, or COVID itself can also induce hyperglycemia due to several mechanisms. I'll be discussing about the later part, that is, how can a person develop hyperglycemia post-COVID or during the COVID illness. Some of the slides which I have been sent contain management of type 2 diabetes during the COVID pandemic, but I'll skip that because the next speaker, Dr. Banshi Saboo, is going to talk about the management of diabetes during the COVID situation. So we know that there is a bidirectional relationship between COVID and diabetes. It's an unholy interaction of the two pandemics. COVID-19 will increase the risk of diabetes, and diabetes in turn increase the risk of COVID-19 as well as the severe COVID infection. We know that diabetes is associated with poor innate immunity. There is more pro-inflammatory cytokine production in diabetic patients. There is down-regulation of the ACE2 levels, which will lead to more severe COVID-19. On the other hand, COVID-19, because of its direct effect on the beta cell, can cause beta cell damage, can cause insulin resistance. COVID itself can cause cytokine release and futin A release, which can also lead to hyperglycemia, insulin resistance. Moreover, the drugs, especially the corticosteroids, which we use COVID-19 also induced significant amount of hyperglycemia, and we have seen so many incidences of steroid-associated diabetes or steroid-induced hyperglycemia, sometime to the extent that the patients have developed ketoacidosis, and of late they have been developing mucormycosis also. So managing hyperglycemia is extremely important, which Dr. Bansi is going to discuss. So I'll skip that part. We already know the interrelationship between the COVID-19 and diabetes. In diabetes, we know there is chronic low-grade inflammatory response, and there's glucose variability, hypercoagulability, which obviously increases the risk of COVID-19 illness as well as its severity. And if you look at this study done by Chinese people way back in 2020, it showed that people with diabetes have less survival compared with people without diabetes. And the difference is the hazard ratio of 3.17, meaning thereby that diabetics are at 3 times higher risk of dying because of COVID. One of the most important comorbidities in the COVID-19 infection is diabetes along with hypertension. And we know that this is a double trouble. Both diabetes and hypertension coexist in about 60 to 70% of the patients, making them more susceptible to severe COVID illness. I'll not discuss why diabetes is a risk factor for COVID-19. I'll go other way around and I'll skip some of the slides for this reason. I'll be discussing how does COVID cause hyperglycemia. One of the most important reason is COVID causes respiratory distress and endothelial injury. It can also lead to some myocardial problems. It can also lead to hepatocyte injury, and all this will release adipocyte as well as the cytokine formation. And the cytokine will in fact have effect on the beta cell, which will impair the insulin secretion. It will also impair the glucose dispersal, and there is increased counter-regulation in a person who has severe COVID. Because of all these things, there is beta cell injury and sometimes leading to permanent loss of the beta cell. Also, there may be trigger of autoimmunity, which we will come to know maybe after 1 or 2 years, whether COVID-19 induced autoimmunity and which led to type 1 diabetes or not. But it is too early to say, but Nature has published some articles which have shown that post-COVID type 1 diabetes has been into existence now. We also have seen one patient of post-COVID type 1 diabetes. There was no associated cause, no other viral illness, no family history, no genetic background also to cause diabetes. So probably we believe that it may be COVID virus-induced autoimmune damage leading to beta cell destruction, leading to type 1 diabetes. Of course, very few cases have been reported, but yes, we have to be careful about that also. Because of impaired insulin secretion and impaired glucose dispersal, patient will develop hyperglycemia. If it remains untreated, especially under the background of steroid therapy, it can lead to ketoacidosis, or it can lead to more severe COVID outcomes. And in fact, it can also lead to mucormycosis, which we are seeing now as a new epidemic, especially in the western part of the country. The mechanisms which we already discussed, the findings of hyperglycemia and ketoacidosis in patients with COVID-19 have prompted the question whether there is an underlying diabetes, regardless of whether it was previously diagnosed or not. The simple clue whether this diabetes existed before the COVID-19 illness or not can be taken from the history, whether the patient had history of hyperglycemic symptoms in the past, and more importantly, from the HbA1c level. If the HbA1c is more than 7.5 or 8 at the time of diagnosis of diabetes during the COVID illness, generally you can safely conclude that this patient is having pre-existing diabetes, which has been unmasked or diagnosed during the COVID illness. Otherwise, if the HbA1c is just borderline 6.5 or 7, probably it is the new onset hyperglycemia, maybe due to COVID, maybe due to therapy associated with COVID, or maybe due to the stress that is also associated with COVID, both physical as well as the emotional stress. So how to distinguish the real diabetes from the steroid-induced or the COVID-induced hyperglycemia? The summary of the published evidence for and against the expression of ACE2 in human pancreatic beta cells, and that was published in the Nature, showed that the immunostaining of the human pancreatic tissue sections and immunofluorescence technology showed that there is some effect of COVID-19 virus on the ACE2 expression of the beta cells. And the analysis of the published literature also showed that there are some autopsy findings or the histological findings which have suggested that, yes, the coronavirus has some effect on the pancreatic beta cells. So the potential pathogenic mechanisms, I'll just summarize in this slide. There is interaction with the SARS-CoV-2 virus, increased inflammatory cytokines, increased lipopolysaccharide, increased natural killer cell, increased ROS and IL-6, increased RAS cysteine activation, increased fibrogen and D-dimer. All this will lead to either insulin resistance or beta cell damage, and which will ultimately lead to hyperglycemia. And hyperglycemia, obviously, if severe enough, will worsen the prognosis associated with COVID. Sometimes it can also precipitate thromboembolic events or even the cardiovascular events. Managing hyperglycemia, we can have different drugs, but basically we need to keep the target of 140 to 180. In all cases, we should not allow severe hyperglycemia as well as severe hypoglycemia to occur so as to have the best outcomes. How do steroids affect the hyperglycemia? We know that steroids will cause protein catabolism, so the amino acids will cause glucose release. There will be more gluconeogenesis, conversion of pyruvic acid to acetyl-CoA, and glucose 6-phosphatase activity will be hampered, as well as the fructose 1,6 activity will be also hampered, again leading to more gluconeogenesis, hyperglycemia. It also affects the glucose uptake and oxidation. There is less glucose uptake peripherally, again leading to hyperglycemia. It also leads to beta cell hyperplasia, increased glucagon secretion. So there is insulin release, which is also increased. Glucagon is also increased, but the net effect is glucagon predominating and increasing the hyperglycemia. And there is effect on the adiponectin as well as TNF-alpha. Increased abdominal fat is the result. Increased lipolysis in the peripheral fat. So all these combined will lead to severe hyperglycemia in steroid-treated patients. What is the impact of diabetic in patients diagnosed with COVID-19? We know that diabetes negatively affects the COVID outcomes because of hyperglycemia, because of the inflammatory state, because of the impaired coagulatory state, procoagulatory state in diabetic patients. Obesity and associated lung problems will also worsen the prognosis, and many of our diabetic patients are having cardiovascular disease as well as hypertension. Most of our diabetic people are overweight or obese also. And especially this obesity in our Indian patients is central, which is associated with insulin resistance, chronic inflammatory state, endothelial dysfunction, hyperglycemia, and hypertension, again complicating the COVID-19 scenario. Well, this we have already discussed, so I'm going to skip some of the slides, but very well demonstrated fact is that COVID-19 and diabetes is a very bad marriage. Both will affect each other negatively and will have worse patient outcomes as far as diabetes and COVID combination is concerned. What are the reasons for the fluctuation of glucose in patients with diabetes? Well, one is regularity of the diet, especially if the patient is hospitalized, then the dietary changes are significant. But even at home, sometimes the whole family may be quarantined. They are getting tiffins from outside. So the dietary pattern is not only irregular, but also erratic and may not be up to the mark which a hyperglycemia person may require. There is reduced exercise. There are GI symptoms because of the illness as well as the drug, which also affect the diet, resulting in the glycemic variability. There may be interruption or non-standard treatment with OAD in isolation wards, resulting in glucose fluctuation. Which we have seen these days that a lot of patients with diabetes are not managed well whether they are at home or at a hospital, number of anti-diabetic agents the dose should be modified does not happen really because of the large burden the doctors are also having about the COVID patients during the large waves. The fear, anxiety, and stress also increase the glucose levels and induce glucose fluctuation. The virus itself can cause human body to produce a large number of cytokines, and because of this physical stress, there are fluctuations. Steroids we already discussed can cause significant fluctuations, and the typical hyperglycemia the steroids causes, fasting may be normal or even low, and postprandial may be significantly high. It is not surprising to see fasting of 80 and postprandial of 400 under the setting of steroid-induced hyperglycemia in type 2 diabetic patients. The stress conditions like infection also increase the glucocorticoid secretion, and that can also complicate the situation even more. What are the consensus recommendations? Well, Dr. Bansi is going to talk about that, so I'm not going to deep dive into that. Some of the drugs which have beneficial effect, one of them is metformin, the other is DPP-4, but now we have evidence with even SGLT2 after the DARE-19 trial done with dapagliflozin in severe COVID patients. And it is also shown that because COVID is associated with endothelitis, even SGLT2 inhibitors may have beneficial effects. Having said that, we must be very careful in using them in severe patients because they may be at risk of hypovolemia, they may be at risk of hypotension and euglycemic ketoacidosis, so they are best avoided. So the key points are people with diabetes developing COVID-19 are at increased risk of complication and mortality, but very importantly, other way around is also true. COVID-19 itself can cause severe hyperglycemia due to its direct effect on beta cells or due to the stress created by the lack of physical activity and the dietary irregularities. Moreover, the steroids which are used for treatment of COVID can also induce severe hyperglycemia, leading to even ketoacidosis. So with this, I would like to stop here, giving the background that COVID can induce diabetes. In our practice, we have now reported about 80 people developing diabetes after their COVID infection, either during COVID or after COVID. We do not have yet published this article, but it is preprint, but about 50% of them have been new diabetic people. Rest of them were probably having diabetes, but it was unmasked during the COVID illness. So pre-existing diabetes, which was diagnosed during COVID illness, is about 50% of them, that is 40. And rest of the 50% are having new onset diabetes after COVID illness. So the figures that are estimated post-COVID is that we are going to have a huge bulk of new onset diabetic patients after the pandemic is over or during even the course of the pandemic. With this, I would like to end, and it's over to you, Dr. Mohan. Thank you so much.
Thank you, Sir Sanjeev, for that excellent talk, for sticking to time and emphasizing the fact that diabetes and COVID has a bidirectional relationship. And I'm sure during the ensuing after the the three talks, we will have a discussion, and there could be, I'm sure, about the number of questions which will be directed to you. So be around. I have the pleasure of inviting Dr. Benchi Sabu, who will be now taking over and telling us about the importance of how to manage diabetes, especially in the setting of COVID. Over to you, Benchi.
Thank you. So let me start with the slides. I think, is it visible perfectly? Yes. Sir.
Yeah.
So first of all, thanks Torrent for giving me an opportunity, and thanks Torrent also for collaborating Diabetes India for this wonderful webinar. And after listening Sanjeev Pathak, he had talked very lucidly about diabetes and COVID, and what I will be talking in next 20 minutes, the managing type 2 diabetes during post-COVID. And thanks Dr. Mohan for your kind words and for kind words of introduction. So we know that about COVID-19 outbreak caused by this novel coronavirus. I need not to talk about it because now it is present all around the world. So we need not to talk about it. The prevalence of India, if you see the number of patients of coronavirus cases, but the point is here that how many of them are recovered. That's good number of persons out of 2 crore 96 lakhs. We have almost 2 crore 83 lakhs. They all recovered because of COVID. But there were few deaths, we all know about it. But very important thing that COVID-19 and diabetes and obesity, we may call it diabesity, they are very much linked. They are very much interlinked because we had seen the patient with COVID-19, not only that increases morbidity with the patients who are diabetes or obesity. And there are a few things which are also common. That one of the common things that COVID-19 also increases the insulin resistance, like the diabetes and obesity. Both these conditions, the COVID-19 have increased inflammatory state. Definitely it is acute, while in diabetes and obesity, it's a chronic inflammatory condition with endothelial dysfunction along with hyperglycemia and hypertension. In COVID-19 also there is inflammation and there is an endothelial dysfunction. Both the things also damage blood vessels and nerves, and that's how it can have acute inflammation in the system, maybe having stroke, maybe coronary artery disease. There is a decreased diaphragm excursion and lung function, which is more common in obese persons like a Pickwickian syndrome. And in COVID-19 also there is a pulmonary inflammation and ARDS. In COVID-19, it can lead to myocarditis and heart failure. We do see these type of patients with diabetes and obesity because of cardiomyopathy and the heart failure. The diabetes also leads to kidney problem, and in COVID-19 as an inflammation, as an acute infection, it can lead to acute kidney injury. And there is a COVID-19, there is a cytokinin storm and increasing coagulation, which may be a terminal problem in patients with acute COVID-19 hospitalized patients. While in diabetes and obesity, because of increased inflammation, they are also having higher risk of increasing the coagulation problem, and they also have higher TNF and high CRP value too. How COVID-19 can lead to diabetes? It is well established that patients with diabetes are at increased risk of developing COVID-19 and its severe manifestations. I mean, those who are diabetic, maybe because of their immunosuppressed, they are more prone to develop the COVID-19 infection. In November 2020, a global analysis which was published in the Journal of Diabetes, Obesity and Metabolism, and which had found that up to 14.4% people who were hospitalized with severe COVID also developed diabetes. I mean, those who were hospitalized for COVID, primarily for severe, they have diabetes too. I mean, they develop diabetes. What exactly causes diabetes in this patient? Most of these patients were perfectly healthy before being infected, and they were actually exercising also regularly. Several cases of type 2 diabetes diagnosis have been reported in people who had COVID-19. These findings suggest that there might be a bidirectional relationship between COVID-19 and diabetes. Diabetes is associated with increased risk of severe COVID-19, and the pancreas that at the risk of type 2 diabetes is not able to acutely increase insulin production in response to these acute stressors. That's the reason the glucose get increased, and this is what happened in COVID-19. How COVID-19 bring out type 1. Now, when COVID-19 came in March 2020, we were thinking that as it is a viral infection, there will be more autoantibody, and that could lead to autoantibody, autoantibody induced beta cell destruction. So we will have more type 1 diabetes. So there are small studies which had shown there is increased risk of type 1 diabetes or increased rates of new type 1 diabetes who were diagnosed in this 2020 and 21. The prior illness causes the body immune system to increase production of all antibodies, and including the pre-existing one, those which are directed against the islet cells of the pancreas that produce insulin. This immune system attack leads to sudden loss of insulin producing beta cell, and this leads to acute hyperglycemia. Once the immune system activation subsides as acute illness resolves, pancreas may resume making some insulin. And if it is typically in a type 1 patients, we may have a honeymoon phase, which will be also there in these patients. This honeymoon period may last for a few years, few months, or a few weeks, depending on different person, it will be different. The honeymoon period occurs because there are still few insulin producing cells, and autoimmune process needs more time to destroy these cells. How it can lead to type 2. There are 3 scenarios that could explain why someone may diagnose with type 2 diabetes after surviving a bout with COVID-19. The person has already diagnosed. I mean, he was having disease, but he was not diagnosed. It was completely undiagnosed person who was having COVID infection, and during that, the investigation was done. The other condition, person may have a pre-diabetes. He is at the high risk of developing diabetes. He may have because of inflammation. He might be on the steroid treatment that had finally pushed them into having diabetes. And for example, you have an acute stressor which increased the insulin resistance, and enough that relative deficiency of insulin production was revealed, and that glucose went above the normal. The third condition could be the person may have been genetically at risk with mild stressor, like an obese person or mildly overweight, but not completely sedentary. And the combination of insulin resistance, which is because of acute infection, maybe some steroid dose, or there is already an insulin resistance which increased because of this, or stress induced. This may also lead to a new onset of type 2 diabetes, which may be there, or the condition pancreas just was not able to increase its output to that level. That is what we call is stress induced hyperglycemia. So another possible reason could be increased inflammation inside the body that is caused by coronavirus. So the inflammation itself may be the cause for that. Inflammation itself is going to increase the insulin resistance. Another potential explanation could involve the ACE2, that's a receptor which is also there at pancreas beta cell, and which is also responsible, or which may be responsible for them to have a decreased insulin secretion. This is the protein on the surface of cell that coronavirus uses to enter and infect them. So ACE2 is found in the pancreas and other organ and tissue that play also an important role how our body process glucose. When coronavirus locks on ACE2, our pancreas cell might not be able to do their normal job of releasing insulin and processing the glucose, and that may be the reason for them to develop hyperglycemia, which is typical of type 2 diabetes. These two new NIS supported studies which are available as a pre-proof in the Journal of Cell Metabolism, which helps to answer this important question that confirms that how SARS-CoV-2 can target and impair the body insulin producing cell. The other is both studies confirm the infection of pancreatic beta cells and autopsy from the people who died of COVID-19, and that additional studies also suggest that coronavirus may preferentially infect the insulin producing beta cells. Beta cells and other cell types in pancreas express the ACE2 receptor protein, and this enzyme protein and neuropilin NRP1, all of which SARS-CoV depends upon to enter and infect human cells. The coronavirus in both insulin producing beta cells and several other pancreatic cell types in the studies of autopsied pancreatic tissue. These new findings also showed that coronavirus infection changes the function of islet and the pancreatic tissue that contains beta cells, and both these teams report induce the infection with SARS-CoV lead to reduced production and release of insulin from pancreatic tissues. The infection leads to directly to the death of some of these important beta cells, and they showed this could be avoided by blocking this NRP1. In addition to the loss of beta cell, this infection appears to change the fat of the surviving cells also. So one side, some of the beta cells which are killed, but some of those who are survived, even they also change the fate in single cell analysis. To get a careful look at changes in the gene activity within pancreatic cells following SARS-CoV infection, these studies show that beta cells go through a process of transdifferentiation in which they appear to get reprogrammed. And in this process, the cells being producing less insulin and more of glucagon, a hormone that increases glucagon, glycogen in the liver to broken into glucose. That is what we call is glycogenolysis. They also begin producing higher level of digestive enzymes that called trypsin. And importantly, they also showed that these transdifferentiation process could be reversed by a chemical that is called trans-ISRIB, known to reduce an important cellular response to the distress. The consequences of these transdifferentiation of beta cells are not very clear. but would be predicted to worsen insulin deficiency and raise blood glucose level. More study is needed to understand how SARS-CoV-2 reaches the pancreas and what role immune system might play in resulting damage. Potential mechanism that increases the risk of COVID-19 in diabetes. The Sanjeev had also talked about it, that how entry of COVID in respiratory tract infection, and then there is a pneumonia with the infection of respiratory epithelium, necrosis of respiratory epithelium, and that leads to pneumonia. This pneumonia may have systemic inflammation, ARDS, multi-organ failure, cytokinin storm because of dysregulated immune response, impaired antigen presentation, and these all are responsible for increasing the insulin resistance and inflammation, systemic inflammation also. This also have direct impact on the impaired neutrophil recruitment, impaired macrophage activity, and impaired IFN alpha production from NK cells too. The effect of type 2 diabetes and glycemic control on a survival of patients with COVID-19 who are admitted in the hospital. You will find the patients who are in compared to non-type 2 diabetic. I mean, this is a significant difference which you can see in 28 days. The significant difference between the persons with non-type 2 diabetes and non-type 2 diabetes, a Kaplan-Meier curve in figure shows that patients with type 2 diabetes have significant worse 28 days survival probability in compared to those who are without diabetes at the time of hospitalization. And this you can see well controlled and poorly controlled. So I always tell my patient that even if you have a type 2 diabetes, there is a significant difference between a well controlled and poorly controlled diabetes. One may have diabetes, but that does not mean that the morbidity and mortality will be higher. Definitely it may be higher in compared to non-type 2 diabetes, but in compared to poorly controlled, a well controlled will be a much better in compared to poorly controlled diabetic patients also. The COVID-19 mortality according to diabetes with or without diabetes, these are the multiple papers which were published. Most of these starting papers were from the China only, Wuhan, and then other papers which were published from this Baron et al. Cohort studies. Is a big population study which they had talked about the with diabetes and without diabetes, and you can see there is a significant difference between a p-value, those patients without diabetes or without diabetes, as far as the mortality according to diabetes is concerned. The selection of guidance and recommendation relating to routine care in people with diabetes during COVID-19 epidemic. The inpatient diabetes service, inpatient diabetes patient will need continuing potentially increasing capacity, will need for a team approach. But one very important thing, that glucose is a fifth important vital sign. So the glucose monitoring or sugar monitoring is very, very important. So after the pulse oximeter, when we are measuring the oxygen saturation, I think the second important, other than the pulse, temperature, and blood pressure, is very, very important, is the glucose monitoring, and that has to be done in each and every patient, whether somebody is diabetic, non-diabetic. It could be first time detected after steroid. So it has to be regularly monitored the way we are monitoring the pulse oximeter or we are monitoring the oxygen saturation. The face-to-face consultation, if not possible, they may continue, but they can do the online consultation the way we are talking to each other just now on this platform. The similar way the patients can also talk to their doctor, and there is a possibility of virtual consultation, which is almost like a face-to-face consultation, which they can do. The virtual consultation, which we do regularly on telephone and email, this they can send all their reports on a mail. On one side, you can see the reports, other side, you can see the patients on a face-to-face, and we can have discussion. Even those patients who are hospitalized, and we as a diabetologist like me and Sanjeev may not have visited the hospitals, but we're taking care of our in-hospital who are admitted and who are still in the hospital, and we are not visiting them face-to-face, but still we are doing the consultation with the nursing staff, with the doctors on duty, and giving them the advice and to keep their tight glycemic control. That's what we can do. The routine diabetes care has to be continued with these patients. The medication are to be continued along with the self-monitoring of blood glucose. Now the systems are there. They can have an app and they can share this data with their healthcare provider. The problems mainly with the foot care services and pregnancy. Those who have problem related to foot, again the video consultation is very important, but sometimes these patients with a foot problem, they have to see the doctor face-to-face, and it require clinical examination, and they may require even some sort of a surgical intervention also. So it's better with the person with diabetes, with the food problem, should be there in the clinic to see their doctor face-to-face. The pregnancy services, again, other than online consultation with the GDM or the hyperglycemia and pregnancy, they may require sometime face-to-face consultation, but they will be requiring more online consultation with our dietitian, with our educator team, and to put them on a continuous glucose monitoring, sometime they need to come to the clinic also. The blood test for the person with diabetes can be done, because in India, most of the lab, they give the service of home collection of the blood. So that can be done. But other than that, they should do self-monitoring of blood glucose, which is very, very important. Now, the issue comes when like fundus screening is to be done. Those patients who are not, they could not get their fundus examination in last 1 year, they had to come to the clinic. Most of the diabetic clinic now, they have the fundus examination system, so they can come to their doctor, and at the same time, they can get their fundus examination also. But if they have retinopathy, they may require more intervention by the retina specialist doctor too. So the flow chart is like evaluate at the time of admission those who are diabetes, if they have risk factor like hypertension, diabetes, obesity, smoking. One thing itself, it puts on the higher risk because they have diabetes and obesity, which is very, very high. And these patients, use the molecule which can be given. If somebody is getting up to the hospital in a room, I think no molecule is contraindicated, but still it is better to avoid some of the molecules like GLP-1 or metformin or a glitazone. But now the data with the low dose sulfonylurea, SGLT2, which can be continued, but preferred choice is always a DPP-4 inhibitor in compared to the other molecule, which is found to be more safe and which found to be less side effects profile point of view. These patients may require more continuous glucose monitoring or more random blood glucose monitoring, preferably if they can put on the insulin if their sugars are not under control, the short-acting insulin and longer-acting insulin. These patients also should be given appropriate anticoagulation. Those patients who are further along with diabetes on very high risk, like patient with coronary artery disease or heart failure or CKD, these patients will require ICU setup. And once somebody is on ICU, I think the only thing which is to be continued is insulin, insulin, insulin. More than insulin, these patients will require a very, very strict monitoring, because that is like too early, sugar is to be monitored. And if they are to be given steroid at any point of time, the monitoring requires much more. There are biochemical markers which are to be monitored in a patient who are in ICU or in hospital with COVID-19. I don't think I need to talk about it, but that we will discuss during our discussion also. The recommended to use those patients who are uninfected but living in environment with prevalent COVID-19. I think they can continue the same anti-diabetic agents, but keeping their sugar control is very important. Those patients who are ambulatory but mild disease, it means they have infection but there is no issue, they can again continue the similar type of medication, whatever is given. The hospitalized patient, as I told you, the insulin DPP-4 are better choice in compared to the other molecules. Can be used with caution. That is what we always talk, that sulfonylurea can lead to more chance of hypoglycemia. Alpha glucosidase inhibitor, because of their gastric upset, sometimes we don't want to give the patients who are in hospital, and the patients who can be given continued with SGLT2. That is what the recent data from an in-hospital patient using a dapagliflozin had shown, that there is no negative impact. But because SGLT2 increases the risk of genitomycotic infection, so you have to be more cautious while using. The not recommended is definitely glitazone, and patient who is in ICU, probably SGLT2 inhibitor we would not like to give. What are the potential accentuated clinical process after SARS-CoV infection in people with type 2 diabetes? The infection with COVID infection will have increased tissue hypoxia, increased metabolic rate, increased interstitial lung damage, and that is acute respiratory distress syndrome. The other part of infection is dysregulation of glucose metabolism, which will increase the glucotoxicity, increase the glucose level. The aggravation of inflammation will have more endothelial damage. The immune modulation will increase the oxidative stress and increase the cytokinin production. So, I mean, the infection itself will have three main things. One is viremia itself. Then Because of viremia, there is increased metabolic rate, and they all going to have the more problem, the dysregulation of metabolic problem, which is like glucotoxicity, then inflammatory phase where more of an endothelial damage, and immune phase or immune modulation that leads to cytokine storms, and that leads to multi-organ dysfunction, which leads to increased mortality in patients with COVID infection, and particularly it is more with the uncontrolled diabetes or persons with diabetes. So these are the ways how COVID-19 can increase the risk of morbidity and mortality in the persons who have already dysglycemia, or it itself increases the risk of glucotoxicity. All these factors which contribute to increased severity of COVID-19 and rapid progression to cardiorespiratory failure in patients with type 2 diabetes. So the key opportunity to transform type 2 diabetes care, particularly in post-COVID-19. So what we can do, we can't say that something like post-COVID. We are saying now this is the era of the COVID itself, whether we will have 100% post-COVID when there won't be any COVID. So what we are talking mean post-COVID means somebody who had already developed COVID. So what I will say, what the things which we can do, if he is not diabetic, he had not become diabetes, we should talk that how prevention of type 2 diabetes can be done in future. He might be at the risk of developing type 2 diabetes in future. The second, those who have developed diabetes, either they were obese, they were metabolic syndrome. So how the possibility that can we do the remission for these persons? Is it the way by which we can do the diabetes remission? That is with intensive lifestyle modification we can do. Those who are already diabetes, or they were uncontrolled diabetes, or they were having mild complication, then we have to prevent complication. It means they have some mild issue, the prevention of complication, that should be our major focus for those patients. Those who are having mild complication, may not have any complication, please try to detect or treat these complications. So you have to check for everything, the cardiac, for eye, for food, for everything. And last is those who are in the hospital, safe care during hospital admission, because the second important part which I am going to talk about, the mucormycosis also. The ABCD recommendation is very clear. The A for A1C, blood pressure, the cholesterol part, and the diet. So that all has to be done in the patients who are from the Association of British Clinical Diabetologists, and they had put for primary care that you please review all the patients whose A1C is more than 10, who have uncontrolled hypertension, or those who have complete hypoglycemia unawareness, those who have diabetes related admission for diabetes ketoacidosis, those who have eGFR of less than 30, active diabetic, foot disease, or those who are recently discharged from the hospital or changes in the treatment, other factors like severe mental health illness or learning difficulties. These patients should be offered virtual or face-to-face appointment within 3 months and may need between 3 to 6 contacts in next 12 months. The other recommendation by Association of British Clinical Diabetology, these patients who should be given priority, who have A1C of less than 10, but still it is between 8.5 to 10, and eGFR is not like less than 30, but it is still between 30 to 45. The COVID-19 associated mucormycosis, and I think in Western India, this had really created a big issue because of the steroid-induced severe hyperglycemia. It is also COVID-19 which make them more prone to develop this infection, and there are other factors. But one of the important factors is a uncontrolled diabetes, and along with that, these patients were put on a systemic glucocorticoids, which will have further the immune suppression. And unfortunately, widespread use of steroid and the secondary or bacterial or fungal infection is really cause for this deadly infection. That is what we call is mucormycosis. The mucormycosis is an invasive fungal infection. It usually affects poorly controlled diabetes. Cutaneous mucormycosis can be classified as a primary or secondary. In primary disease, it is skin is infected. In secondary form, it is disseminated from other location, more common from a rhinocerebral infection, and it can be subcategorized according to the pattern of infection, like localized, deep, or disseminated mucormycosis. The types of mucormycosis: rhinocerebral, which is the most common, which what we see; the pulmonary mucormycosis, again very common mucormycosis; and GI mucormycosis, which is more common among young children and with adults, what we see. The cutaneous skin mucormycosis after fungi enter the body through a break in the skin, and this is most common form of mucormycosis among people who do not have weakened immune system. The disseminated mucormycosis has been widespread, and these are the ones even you will find in spleen, heart, everywhere, brain. So this can also have a disseminated mucormycosis. The symptoms of rhinocerebral, one-sided facial swelling, headache, nasal, sinus congestion, black lesion, and that's the reason we call it black fungus, fever. Where mucormycosis comes from, they are present throughout the environment, particularly in soil associated with decaying organic matter, such as leaves, piles, or animal dung. They are more common in soil than air in summer and fall them in winter or spring. These fungi are normally not harmful. However, for people who have weakened immune system, breathing in mucormycosis spores can cause an infection in the lung or sinus, and which can spread to other parts of the blood, other parts of the body. So, this is through the inhaled system, it can go, but only with those who have weakened immune system. The clinical features, the rhinocerebral infection is been seen with the patient with diabetes or a post-transplant. Symptom may have a unilateral facial swelling, which I already talked. They may have some nasal discharge, fever may be also there. As infection is spread, it can have ptosis, proptosis, loss of extraocular muscle function. There are vision disturbances which may occur, necrotic black lesion on a hard palate or nasal turbinate, and drainage of these black pus from eyes are usual diagnostic sign. The transmission occurs again through inhalation, inoculation, or ingestion of spore. Although most cases are sporadic, healthcare associated outbreaks have been linked to adhesive bandages, wooden tongue depressor, hospital linens, negative pressure room, water leak, poor air filtration, non-sterile medical devices, and building construction. But these are uncommon in compared to the more sporadic case which we see with the patients who are immunocompromised. It can also spread between the people or between the people and animals too. So post-coronavirus, the objective is to study the possible association between a mucormycosis and coronavirus. The methods was they have taken a prospective observational study which was conducted at tertiary care center over 4 months, and this is what the all patient had a primary disease infection involving ethmoid group of sinus air cells, and maxillary cells was infected almost 12 out of 23 cases in compared to the other sinus. These are the pictures of the CT scan which had shown that how diabetes is responsible or increasing reason for these patients to have a mucormycosis. The results was 23% patients with mucormycosis had an association with coronavirus. The ethmoids were the most common sinuses which were infected. Intraorbital extension was seen in 43.47% of cases, while intracranial extension was only seen in 8.69%. Diabetes mellitus was present in 21 out of 23 cases, and it was uncontrolled in 12 cases also. All patients had a history of steroid use during this coronavirus treatment. So, I mean, you can see corona, steroid, diabetes, and mucormycosis. A deadly quadrant. This you can see that all 4 things was present almost in all these patients. The conclusion of this paper was the association between corona and mucormycosis of the paranasal sinus must be given a serious consideration. Uncontrolled diabetes and overzealous use of steroids are 2 main aggravating factors, and both these must be properly checked. Guideline is how to prevent: use mask, wear shoes, long trousers, long sleeves, maintain personal hygiene. But I think the most important thing is a controlled diabetes, and not only more control, it is more of a monitoring of the sugar that is also very important. And those patients who are put on a steroid particularly, they should be tightly monitored and tightly controlled. And please involve diabetologists in the team. I mean, that is one of the most important thing, where the physicians and the critical care physician and infectious disease specialists, they can involve it, because it's like sometimes a vision is like that they are treating primarily only the COVID or COVID related complication, but this is one thing which is neglected. This we had seen that it has been neglected. So it's better to create a team of the doctors who are taking care of different parts of, like pulmonologist is taking care the infectious disease, the physicians, the critical care, diabetologists, as and when they are needed, the team has to be there to take care of all these patients. So a tight glycemic control is definitely going to decrease the chances of this deadly mucormycosis infection, and definitely when to suspect, how to prevent, and what are the things which we should do it for the persons to have a high sugar, that all we know, and that we should continue to do it. So the guideline is very, very important, that how to manage and control diabetes. This is the most important thing. I don't want to go here for the antifungal therapy and the surgical part of the mucormycosis, because that is all late. I think before that, we should try to prevent each and every person for getting this deadly infection. The suspect and confirmed mucormycosis, they are an emergency. They require a rapid action. Again, as I told you, I may not go for the treatment part of it, because that is a liposomal amphotericin or a posaconazole IV. So they are all antifungal, and I think physicians or a infection disease specialist can better give answer for all these things. So I'm not talking about more about the therapy part of the fungal infection. But one thing is very clear, even we have today the vaccine. So one thing, all these are healthcare professionals and all doctors, we should try to promote more of vaccination, but still with all COVID appropriate behavior. And what COVID appropriate behavior is: washing the hands more often, using the hand sanitizer before or after touching anything, wearing the mask, don't touch your face. That is most common. So these are the few things which is appropriate COVID behavior, which we should maintain continuously, and we should try to promote vaccination as possible, as much as possible, whatever we can do, and tell your colleagues, your relatives, your friends, and your subordinates for getting vaccinated as early as possible. Thank you. Thank you very much. Once again, thanks, Torrent, for giving an opportunity, and thanks, Torrent, for collaboration with Diabetes India. Thank you. Thank you very much.
Thank you, Benchi, for that exhaustive presentation. And emphasizing the fact that the hyperglycemia has to be attended and given priorities to prevent the complications. And I have shown multiple guidelines. In fact, the government of India and the Health and Family Welfare presented its, from 1st of June, presented its guidelines on the clinical diagnosis and management of diabetes during COVID, version 2. We can discuss if the time permits. And I have the pleasure of inviting, again, one of my friends, Mangesh Tivaskar, for the long COVID. And that's again interesting. Mangesh, please.
Thank you very much, sir. Thank you. Good evening. And hi, Banshi. I was rocking as usual. And thank you, Sanjeev. Thank you, entire Torrent team. And Monan, sir, you are superb as usual. Now, Bansi has beautifully summarized. And probably, Sanjeev started with the story of COVID and what happens to diabetes. And because of them, thankfully, we are very well aware about it. It's the efforts of Banshi and all that. But here I am, friends, to talk to you about long COVID now. Bansi says that there is nothing like post-COVID yet, but yes, we are in a situation where probably we might have to start thinking about and get prepared about what we know as long COVID. So before I start my talk, let me tell you guys that this is what I have probably gone through. The discussions are going to be based on the recent NICE 2021 guidelines, NIH guidelines, IDSA, ICMR guidances, and of course, some recently published literature in peer-reviewed international journals. I'll not be discussing any organ-specific or system-specific management because that is too much of thing. Now, Bansi has beautifully done that, and we all are appreciated as far as our COVID-related care, probably diabetes and COVID-related associations, along with Association of Physicians. Bansi was instrumental in coming out with the guidelines for the telecommunication for diabetes management or the distance management as well. But then how much we are prepared for this scenario of plan, prepare, and perform as far as the COVID and the long COVID syndrome is concerned. It's a long way to go. So let's start talking about this. And isn't it worth contemplating that since the inception of the COVID pandemic, we are mostly busy in getting worried about the number of the cases, the transmission, the hospitalizations, the recoveries, the deaths, the preventions, the variants, etc., etc., etc. But we hardly discuss anything related to long COVID, which is the reality of life. So how do you define a long COVID situation? When you will say that this is a long COVID situation? This is probably a sort of a reading of nearly 60 different publications I could do, including the various guidances. And I ultimately concluded that there is no specific definition still. But we can sum it up shortly by saying that, long COVID syndrome, what we always now talk about, is a presence of symptoms or signs related to COVID for more than 12 weeks, provided they are not explained on any other diagnosis or any other challenges. Now, remember that in the clinical case scenarios, the definition of long COVID is commonly used to describe only signs and symptoms, which probably continue or keep on developing after COVID situation. But remember that they can be still ongoing when you talk about COVID and the around disorder. So we need to very, very clearly define what do you understand by long COVID syndrome. So grossly, long COVID syndrome can be classified into two different categories. Number one is a subacute or ongoing symptomatic COVID, which is a period immediately after COVID from 4 to 12 weeks beyond the post-COVID acute illness. And the chronic or post-COVID syndrome or long COVID syndrome is usually the symptoms which persists beyond the 12 weeks of period after the COVID. And this is what the natural history, where we all know that this is the way that the COVID progresses. But look at beyond 12 weeks and look at the number of the symptoms that you're getting beyond 12 weeks or probably after the end of 6 months. So if you keep on thinking about it, as you understand long COVID more and more, you will realize that long COVID syndrome can not only involve your pancreas or your diabetes or your cardiology or probably kidneys or something. It can manifest as a symptomatic involvement of each and every organ. And probably today's webinar signifies that, because we have a physician talking to you with the force which has been guided by the cardiologist along with the two brilliant diabetologists. So imagine, this is what the COVID is. Nearly 55 or more symptoms, fatigue being the commonest one of the post-COVID syndrome, unfortunately neglected the most. The other common symptoms are like headache, attention disorders, post-traumatic stress disorders, hair loss, depression, anxiety, memory loss, and so on and so forth. So it's a multi-systemic disorder. But the commonest presentation of the post-COVID scenario is the persistent fatigue, persistent breathlessness, persistent myalgia, persistent arthralgia, chest pain, vision problems, cough. And in very few situations, you may as well get many other symptoms. So the question is why it happens. There are a huge number of explanations for that, and the research is still going on. But grossly, if you need to talk about it, that if you want to understand the pathophysiology of long COVID, probably there are 4 potential prominent mechanisms. Number one are the virus-specific pathophysiological changes, and Bansi alluded to it beautifully as probably immunomodulation happening, or as Sanjeev was talking about, that there can be a challenge as far as the immune response is concerned, or excessive mast cell activation syndrome, or there can be immunological aberrations and inflammatory damages. And of course, we do also have healing sequelae like fibrosis or worsening of the COPDs, commonly observed in the patients, those who are middle-aged, between 35 to 45. But you can see that nearly 70% of the patients are in the range of 25 to 70 years age. Never ever forget that it doesn't matter how mild or severe was your COVID. You can still be vulnerable for developing what we call it as long COVID syndrome. But are there any indicators or pointers which can predict the possibility of development of a persistent COVID syndrome? Yes, of course. People, those who need hospitalization and require oxygen therapy, people, those who had abnormal auscultation sounds, people, those who had breathlessness significantly, are the people, along with the different ages, likely to develop the persistent COVID syndrome or long COVID syndrome, no matter it could be at the end of 30 days or the data is almost similar for the end of 60 days. So there are a few particular features that you should be noticing, that it's commonly seen usually in the age of 35 to 49, but also can be seen up to the age of 70. Women are more likely to be hit than men as far as the long COVID syndrome is concerned. Mostly seen in healthcare professionals or the social care workers, those who are working into a health sector. People with pre-existing health comorbidities like diabetes, hypertension, which are usually more than 1 or 2, are more likely to develop long COVID syndromes. So beware that people can have wide-ranging and fluctuating symptoms after acute COVID-19, which can change the nature over the period of time. So never rule out this post-COVID syndrome. And this is what I am saying, that COVID can have a lasting impact. And you can see on this slide that it has got a multi-systemic involvement. It can involve everything and anything. So how do you assess? You need to have a holistic approach. You need to have the individualized approach, a person-centered or a patient-centered approach. So you need to have a comprehensive history, a comprehensive and appropriate examination, physical, cognitive assessment, psychological and psychiatric assessment, and the assessment of the functional abilities along with your detailed history taking. Also try and understand what was the nature and the severity of the previous disease and what is the nature of the current treatment. Must ask about the history of the health conditions or the comorbidities. Discuss with the patient. Discuss not only with the patients, with the family member, with the caregivers. Listen with empathy. Use those golden words that, yes, I understand that you are suffering. Acknowledge the impact, surely. And especially this is very important when you are treating elderly with post-COVID situation. Express your worries. Express your acknowledgement for their challenges, because most of the times, unfortunately, in elderlies, whenever there is a gradual decline or deconditioning or worsening of the dementia or the mentation, or when the frailty worsens, or the people they complain of, extreme fatigue syndromes, we probably tend to neglect these patients. But remember that always rule out any other possible diagnosis before you label it as long COVID. And hence you need to do few of the tests. I'm not going to go into the details about it, but these are some basic assessments that you can do. Remember that imaging to be reserved only and only wherever it is necessary. But the must part of the COVID examination and investigation is the neuropsychiatric assessment of the patient. You can utilize all other possibilities of or the fraternities of investigations depending on your specialties. Like especially when you are talking about neuropsychiatric assessment, screen for anxiety, screen for depression. Post-traumatic stress disorders are extremely common. Say sleep disturbances are extremely common. Choropsychosis is extremely common. So monitor them. So these are various headings for which various monitoring parameters are given in this. And this is a beautiful paper which was published in Nature. And I would request you guys to go through this, where they have told when and which test to be done for what kind of a post-COVID symptom, so that you know how the patient is doing, especially for the long time. And when you are planning, there has to be a holistic approach. There has to be a involvement of the family member or a caregiver when you are taking a decision. Most importantly, and as it is important in diabetic patient also, self-management is extremely important. And hence, what you require is more monitoring. Teach patients about the red flag signs. Tell them which hospital to go, whom to contact, especially in the need situations. Remember always that severe hypoxia or oxygen desaturation on exercise still stays as a red flag sign. Acute life-threatening complications, you should tell them about that. Worsening of the current illness, they should reach the hospital. Whenever it is necessary, tell them that it is important. Again, I will reiterate the fact that make them to actually monitor themselves on heart rate, SpO2, blood glucose, blood pressure, respiratory rate, and go through these investigations on your follow-up reports. Just do not overlook the patient because you are offering them a follow-up visit. No, you need to be very careful as far as these assessment parameters are concerned. Of course, other services like psychiatry, physiotherapy, occupational therapy, now we all need them. Nutritionist on board, rehabilitation medicine will have a huge role to play when we want to manage long COVID adequately. So it's not a long COVID one specialty situation. You are going to require the respiratory people, the family physicians, the ENT people, the neurological people, the cardiovascular people, the musculoskeletal specialists. All these specialties will form a whole team of the post-COVID management team. There are few unanswered questions which we will surely keep on answering as our knowledge about post-COVID syndrome, the post-COVID situation, and the management will improve. I will leave you here with these unanswered questions. Really keep on thinking about it. But most importantly, we need to understand that post-COVID syndrome or a long COVID syndrome or a long COVID situation is one thing which we all have to be prepared in near future or in coming times. Thank you very much. for your kind attention. Over to you, Mohan sir.
Thank you, Mankesh, for keeping it short and sweet. And of course, quite a number of unanswered questions, which I'm sure the time will tell us and educate us, and we will continue to learn. Now, that brings the end of the three exciting sessions. And thanks everyone for done a fantastic job. So before we get some question from the chat box, let me, and I will request each one of you. Now, each one of you can possibly respond to some of these, because these are
ask all your difficult question to Sanjeev.
No. They're not difficult questions. I suppose they are practical questions. They may, some of them are maybe practical. Some of them may look a little research based also. See, when COVID came, always we said people with hypertension, people with heart disease, people with diabetes had high mortality. And we have data which showed that. But as Banshee has shown a quite number of retrospective data. See, we don't have a large number of prospective data, so much so later now we realize being hypertensive doesn't make you automatically a higher bracket. Okay, so is it happening in diabetes? We know that is a more heterogeneous disease than hypertension. So does every diabetic has the high mortality? That is number one. The number two will be, being a diabetic, does it attract development of COVID? These are some of the questions that your juniors or your other specialty people may ask you. What are your gentleman's answer for
that? So shall I start, sir?
Sure, you're the first one.
Okay. Well, whether the diabetic people get more, rather, whether the diabetic people are at more risk of developing COVID, the answer is yes also, no also. Theoretically, yes, but practically, I think being diabetic does not increase the risk of infection, but yes, it increases the risk of severe infection for that sure. And Bansi showed in his talk that uncontrolled diabetics are at more risk. So that is again an important message. Just being diabetic, but being a diabetic with controlled diabetes, your risk is lower compared to uncontrolled diabetic, especially when the HbA1c is more than 8.5 or 9. The Colorado study also showed that people who are on insulin are at more risk, not because of insulin therapy, but they are having more severe diabetes, and that is why they are on insulin. They are having more aggressive diabetes, more florid diabetes. So patient with uncontrolled diabetes, the risk is definitely much more. Same is not true for hypertension, but yes, if hypertension is associated with diabetes or other features of metabolic syndrome, especially obesity or cardiovascular disease or heart failure, the risk is definitely much more.
Yeah. Banshee?
Yes, sir.
So now, because now we have seen most of these, when you, in unadjusted analysis, when you don't take age, that is what has happened to hypertension at least. Exactly. Diabetes may be different. Correct. That's why the question everybody asks is, what about that? If you account for the elderly, does it automatically the hazard ratio remain same, or is it different? That was the, which worries everybody.
So the elderly people will definitely have the more risk of other complication also, because they may have hypertension, they may have CVD, they may have malignancy, they may have CKD, they may have multiple other comorbid condition. And we know that with elderly population, the risk of hospitalization, risk of severe infections are more, and the morbidity and mortality was found to be more because of other multiple comorbid condition. But diabetes itself is found to be one of the important comorbid condition, because we had seen that even the sugar which is high in a young population, they may not have any other comorbid condition. They may not have CKD, they may not have the heart failure, but still the risk of prolonged hospitalization or morbidity and mortality is higher. So the two important comorbidity which is not related with age is, one is obesity and other is diabetes, and these are two very important. I think now this is the time when we are living in COVID. We don't know whether the third wave will come or not, or whether it will continue, how long it will continue. So this is the time where we can talk to all our, even the lay persons also, those who are diabetes, please try to control it to the target. Those who are not diabetes, at least they should monitor themselves. They may be undetected diabetes, they are at the risk of developing diabetes, and they should be prevented from becoming frank diabetes. Those who are obese, those who are overweight, try to decrease their weight. So these are the two important things which we should do it, all healthcare professionals, for all our patients, to modify their risk for this COVID infection, which may come again, or for any other infection in future. Today is COVID, but maybe after 5 years, there could be some another COVID or some another infection. So these two comorbid conditions for all those who are developing infection have a severe outcome. I mean, bad outcome in compared to the person who does not have diabetes or obesity.
No, you said it absolutely right. You know, this is the time that we should be more careful.
It's an opportunity. It's like
our,
an opportunity.
our lifestyle, but unfortunately, your frequent lockdowns permits now people getting an alibi. I don't want to do an exercise because it is lockdown, and it makes you now your family is all together. You start eating more. So unfortunately, this is not helping us in any way to improve our lifestyle. Mangesh, your take on that?
Oh, I completely agree to these guys. And more importantly, I also say that not only diabetics but pre-diabetics also behave the same way, probably equally bad as the diabetics are likely to behave, especially.
So I just want to make one comment that Mohan, even during lockdown and when everybody is eating together, we have like Mangesh, who is working at home and working for 2 hours every day exercise. Even inside the home, you can see his physique is more improved during this time, and he had not taken anything extra. So I mean, if somebody is highly motivated, it does not make any difference whether the lockdown is there is no lockdown, whether he is eating at home, he is eating outside, he is eating with family. It will not change anything. Rather, if he is motivated, he will take care of complete family. So that's what I think we should educate the people more about this, the benefits of the exercise.
Absolutely. I think the lockdown period can be the best lesson period for all of us to be more careful about our health. Now, whatever it is, COVID has taught us about the essential of importance of health. And even the policymakers has realized that. So that's a very good thing. See, the second, the most frequently asked question will be, how will I treat my diabetes? General practitioners or the physician general who was not trained to treat diabetics. No, of course, everybody are trained, but who are not the regular guys who treat diabetes. Is the same questions. How will I be, what changes should I be making, and whether I can use metformin or whether I should be, of course, all these newer generation molecules people may not be using much, but amongst the available agents, Banshi has discussed extensively on the importance of all the OHAs in the setting. One question, are you gentlemen advocating a continuous glucose monitoring in these sick patients? Number one. Number two, again, to re-emphasize, not to bend, re-emphasize and stick onto the head the fact that what is the best way of treating diabetes during COVID? We can start with Sanjeev.
Okay. Thank you, sir. During COVID, especially a person who has developed COVID, he can continue taking metformin if the illness is mild or moderate. He can continue DPP-4 inhibitor. Even he can continue to have an SGLT2 inhibitor according to the new evidence. But if the disease becomes severe, if patients requires hospitalization, or if there is dehydration or any other signs, insulin is the best way how we should treat a COVID person. So in absence of such comorbid conditions, any of the oral agents can be used. Of course, the contraindications for individual drugs must be carefully observed. If a person develops diabetes during the COVID illness, if it is due to steroids, again, insulin will be a better option. And in such scenario, only basal insulin may not suffice. You will need more of bolus insulins compared to basal, because in these cases, fasting is not that high, postprandial is very, very high. So bolus doses have to be more compared to the basal. DPP-4 are very safe beds. They can be given even with the severe infection. And though they are not as effective as the other agents, but they are very safe. Metformin can be given. So they are also very safe kind of agents to be used during COVID. So these are the three easiest drugs for any general practitioners also who can prescribe these agents. Sulfonylureas, you have to be a little bit careful because they can cause hypoglycemia. So better avoid in mild hyperglycemic states, especially when the fasting is around 150, postprandial is around 200. Do not start sulfonylurea or the HbA1c is below 7.5 because they can cause hypoglycemia. Pioglitazone, generally we do not start de novo, but if patient is already on pioglitazone, if there is no contraindication, if patient is not hospitalized, we can very well continue with pioglitazone. AGIs, especially during the steroid-induced hyperglycemia, alpha-glucosidase inhibitors are also very good drugs for controlling the postprandial. So all the drugs have their own role. We need to individualize the treatment.
Thank you. Banshi, will you like your patients to be continuously monitored, or what is your practice during the COVID days?
So continuous glucose monitoring, we use it for the patients who are on OPD because it is not been very affording. Many of our patients can't afford it for continuously. But the professional CGM, which is costing 2,200 rupees per sensor, there are definitive indications like those patients who are going in hypoglycemia unawareness, their sugar are, it is not correlating with their A1C. When we changing the therapy, all those indications which we do use. Now, during this COVID time, the use of a Libre, which is a new device which had come, Libre Pro instead of that, which is slightly costly sensor, where patient can monitor themselves and they can send their data to the doctors on a distant monitoring, that sort of things which we can do only for selected class of patients who can afford, because the sensor here is costing 5,000 rupees instead of that Pro, which is costing 2,200. So that's number one. But if my patient can afford, definitely a CGM is always better in compared to the self-monitoring. But that does not mean that we will not be talking about the self-monitoring of blood glucose. It is the intensive blood glucose monitoring is always better. Now the second part, will I recommend continuous glucose monitoring who are in hospital? Yes, in the patient in hospital, you can use it, but not for ICU patient, because again in ICU patient, because of inotropic agent, because of the vaso pressure when they are already on it, or they are in hypertension, the peripheral circulation, the interstitial blood glucose level monitored through these continuous glucose monitoring will not be accurate, while those patients in hospital, in room, they can be monitored with this continuous glucose monitoring. So we had used all these modalities of monitoring during this COVID time because we were not meeting face to face. So they had used even the continuous glucose monitoring also, but still we are more dependent on a self-monitoring or a glucose monitor by which they can monitor their sugar even 6 times, 8 times in a day also.
Thank you. Mangesh, your comments, especially during the long COVID.
Yeah, in fact, to continue what Sanjeev and Banshi has talked, there is a good paper which has been published in NEJM recently of what we call it as COVID diabetes, where they have also specified, how to actually intensify the therapy on those patients, those who are probably moderate to severely sick, and depending on the dose of the steroid, how do you manage the steroid-induced hyperglycemia or hyperglycemia which is secondary to the steroid usages. There is a particular way of intensifying the therapy and monitoring as well. So I completely agree to what Sanjeev talked about, that the choice of the therapies here, probably I may say that, you can probably start on with the sulfonylurea, which are usually a short-acting sulfonylureas, maybe probably glipizide, or you can even start on with the gliclazide, which are a short-acting sulfonylureas as a choice of therapy, or even glinides have served beautifully well in these periods. Secondly, what as Bansi has talked about is that what is the key of success here is a management and outcomes related to diabetes is concerned is a good monitoring, whatever the way you monitor your patients. Those who can afford the continuous glucose monitorings like Libre or Libre Pro can very well go for it. Or of course, there is a SMBG which can be frequently done, and now even SMBGs are also available, can be monitored distant by the distant monitoring tools. So we have got so many other assets to add it to the management of diabetes. And as far as SGLTs are concerned, yes, of course, now with the publication of DARE 19 data available, probably yes, there is safety possibility of no harm or probably less harm is definitely established. But if at all it is a de novo situation, then we probably need to decide whether this patient really needs an SGLT. And I would probably say that if the patient is not on SGLT2 inhibitor, probably stop, do not start unless until it is indicated. See to it that the patient is stabilized first, the toxemia is over, the dehydrating situation is over, and then probably you may go ahead with starting on with the SGLTs. And I completely agree to pioglitazone. It's not contraindicated. If the patient is already on with pioglitazone, go ahead. Even the patient is, because one such drug which addresses that steroid-induced insulin resistance worsening, apart from metformin, is pioglitazone. There is no other better drug that addresses that challenge. So I think probably this is what I have to say.
Thank you, and I think the days, I possibly is not the right person to ask it, but then the days where we used to see DK or hyperosmolar, these complications were rare. But are you guys seeing these complications during these COVID days, Sanjeev?
Yes, to a greater frequency than we used to see because of the hyperglycemia the steroids causes. And unfortunately, many of our hospitals who are not so much accustomed to hyperglycemia management, they just continue to treat with the short-acting insulins only and in a sliding scale fashion, leading to severe hyper as well as hypoglycemic conditions at times leading to diabetic ketoacidosis also. So yes, previously diabetic ketoacidosis we are not seeing frequently, but in the COVID era, we had seen quite a few cases, of course, remotely, of ketoacidosis as well as hyperosmolar.
One more condition, Sanjeev, sometimes type 1 diabetic who are relatively young adult or adult patients who are getting admitted, and with the medical officer confuse it like just considering is a diabetes only, and they were treating these patients only with short-acting insulin, and suddenly the longer-acting insulin is being stopped, and that leads to diabetic ketoacidosis because they always need a baseline continuous insulin has to be there on board, and that is being stopped, and that leads to diabetic ketoacidosis. So we are seeing a lot of patients with this complaint also. While the typical very young child who is getting admitted 12, 15 years, most of the time pediatrician and the medical officer will understand that this is type 1 diabetes. But sometimes a 25, 30-year or 32-year-old guy is getting admitted. Actually, he's 100% insulin deficient. And by stopping the basal insulin, the chances of the chances of diabetic ketosis is very high.
So the best policy to prevent these complications will be give due attention to your basal insulin. And one of the ways, I don't know, it's one of the ways, apart from the, give more importance to your hyperglycemia. And of course, now, as all of you have rightly said about the over enthusiastic usage of, now I've seen people putting tons and tons of betamethasone. I don't know. There are guidelines which tell us now this is the dosage, but even doctor patients are complaining that they have tons of they've received. Unfortunately, I think the things will be strained. Maybe we have a couple of minutes more. All of us has been taught initially when the influenza and other Coxsackie and all this came. The etiology of diabetes, it could be a virus, could be an important agent. Are we again educating ourselves about this concept of virus and diabetes, Sanjeev?
Well, it's too early to say, but yes, I can say from experience of one patient, as I already shared with you, that one of our patients has developed insulin deficient diabetes at the age of 21 years. He had COVID last year in June, and in December, he developed insulin deficiency diabetes. He has no family history, and of course, we have not done his genetic studies. He is GAD positive. So 6 months is a period when actually the virus can trigger autoimmunity and can cause type 1 diabetes, whether it was COVID virus that triggered that or something else. We have no idea, but we have to be watchful.
Banshi, your comments?
Yes, so the virus definitely increases the risk of autoantibody. And if you see the type 1 diabetic patients, which are normally what we see they may have history of some brief illness, and which is mostly a viral illness, which you can find, and you can have their autoantibody positivity. As Sanjeev was rightly saying, that in this COVID era, there are multiple papers which are getting published from all over the world, and everybody is looking for that. Like, I am the part of the SWEET registry, which is a international registry for type 1 diabetes, and I am also responsible for Southeast Asia. We have more than 50 centers, and we have collected the new type 1 diabetic patients in last 1 year. In my clinic, we had who are come to my clinic first time, and they were detected during this COVID era only. So we are not only doing their all autoantibodies, but we are also trying to correlate, is it possible that is it because of the COVID, somewhere trying to relate. And all over the world, the data is getting published for this, and probably we will have a better answer maybe in a year or two after that. Will it causing more autoantibody? Does the COVID infection increase the risk of increasing type 1? Is it the incidence or prevalence of type 1 is increasing post-COVID? So we don't know at this point of time the answer, but yes, viral etiology directly increases the risk of increasing autoantibody, and this autoantibody may be increased risk for this. But it cannot be only type 1. Then there has to be other autoimmune disease. Are they increasing or not? So that type of data also, I think, probably in a year or two we will get. So whether what happens to rheumatoid, what happens to autoimmune thyroiditis, what happens to other conditions. So maybe
Thyroiditis is also, there are papers on thyroiditis.
Yes, I am telling you, it will be all autoimmune disease will increase.
Yes.
Mangesh, that is a territory for you, the API energetic secretary, to work on. No, that's a very interesting area. We have just like you have been doing on the importance of telecommunication. I was part of the telecardiology part.
Yes.
Which is an initiative from the API. This could be another initiative, involve the RSSDI, involve everybody to get the information from our country, because we are the capital, or the second, at least we are competing with China. I know about the numero uno position, but then we had enough and more data in our country, and it is time that your comments on that, Mangesh. And then we'll close.
It is high time, and as both of these guys have commented, I have also one more aspect, that virus-related pancreatitis can be also one of the reasons for worsening of the possibility of development of a type 1 diabetes, which can be directly a viral relation as well, apart from the immune triggers that we have or immune disruptions we have. And we still do not have. We have other viruses which are responsible for causation of pancreatitis, and they have been established. So as the knowledge about COVID evolves around, probably we are going to find all these different areas which COVID is going to be culprit and blamed for sure. As for no matter, it could be anything. Like now, being a cardiologist, you will tell me that you have started seeing more frequently acute coronary syndromes. You are seeing more viral myocarditis presenting to you, worsening of the heart failures, flash pulmonary edemas which have come up. The conduction disturbances which have come up, severe bradycardias we are already witnessing, and so many things which are there. So all these multisystemic involvement related to this COVID are bound to come up, sir, in near future. And as you rightly pointed out, really, yes, this is an opportunity for not only API, but all the associations, all the societies, which are academic associations, to take forward this research area and start working on that as well, and generate more India-specific data as far as we talk about all these newer nuances related to COVID.
Thank you. Dear viewers, all good thing has to end sometime. Then our three erudite speakers, Mangesh, Sanjeev, and Banshi Sabu, has educated us over the last one and a half hours about Sanjeev talking about the importance, the genesis of diabetes and its relation with the COVID, the importance of it, the importance of recognizing it, and Banshi detailing us on how to manage it, how to pay more attention to prevent mucormycosis, the deadly disease which is creating so much of concern, and Mangesh again telling us about the importance of long COVID. Again, every one of them telling us, pay attention to prevent hyperglycemia. You can continue to use most of your conventional anti-hypoglycemic, the hyperglycemic agent that you have been using. Of course, if the patient is very sick, there are agents which some hemodynamic disturbances which you can temporarily cease. Then you can always restart them once the hemodynamic situation improves. So the importance is that keep your blood sugar under control, which is very important, and continue to monitor the patient well, and then prevent the long COVID to a great extent. So that gives me thanks for the Amish and the group for the opportunity. Over to you, Amish, or the Pandit.
Yeah. I would request Pandit to
Yeah.
give a lot of thanks.
Amish bhai, am I audible?
Yes.
Yeah. Good evening once again to all of, and on behalf of Torrent Pharma, I take this opportunity to express our sincere gratitude, first of all, to Diabetes India. Today is our eminent moderator, Professor Dr. P.P. Mohanan, and the all eminent speakers, Dr. Sanjeev Pathak sir, Dr. Banshi Sabu sir, and Dr. Mangesh Tivaskar sir. That was indeed a sea of insight. And delegates, you will agree with me that it was a privilege to hear from the all eminent speakers and nicely moderated by Professor P.P. Mohanan. It was a splendid evening which enhanced our knowledge and gave us a new perspective about COVID, India, and diabetes and its management. I would like to take this opportunity to thank you everyone on behalf of Torrent once again, and I'm sure each one of us will gain a lot out of it. Thank you once again. Stay healthy and stay safe.
Say good night.